Hello, my name is Gustavo Oderich. I'm a vascular surgeon in Houston.
Hello, my name is Michel Bosiers. I'm a vascular surgeon at the University Hospital in Bern, Switzerland.
Hello, my name is Nikolaos Tsilimparis, and I'm a vascular surgeon in Munich, Germany, in the University Aortic Center.
Hello, I'm Marc Schermerhorn. I'm a vascular surgeon from Boston.
We are just ending a tremendous session here at Charing Cross 2026. This was a very busy meeting, very successful, and we're delighted to see a lot of controversies and discussions. One of the discussions we had is the management of juxtarenal abdominal aortic aneurysms and complex abdominal aortic aneurysms. And as you know, there is a variety of options from open surgery to off-the-shelf devices, CMDs, and PMAGs. To that end, we put together a group of experts here, and we really would like to nail down some of the concepts and the discussion that we had today. Michel, you guys almost kill each other with this debate, and whether you should use off-the-shelf device or not. And I think this is very interesting because indeed there is potentially a lot of drawbacks with off-the-shelf device in the area of juxtarenal aorta. But can you tell a little bit your stance and the rationale for your approach on these patients?
Yeah, thanks, Gustavo. So I think in my practice, when I have an elective juxtarenal case, I would go for custom-made devices all the time. If I have a symptomatic where I need to do maybe 1 or 2 physician-modified fenestrations, I would go for a PMAG. All the other devices where I need to incorporate 4 vessels, my approach, as I showed also during the debate, despite the higher coverage, aortic coverage you have, is go for off-the-shelf devices. Because we also now, also with the TAMBE, we have shorter aortic coverages now available with excellent technical results. What Nikos also showed in his paper, that the feasibility is around 94% of all those devices for juxtarenal pathology.
Well, we have a principal dispute, which is also the topic of our debate, because my principal thinking of these patients is that you should do the best care always, no matter if emergent or elective. And since we know that fenestrated cases do better in terms of aortic coverage, of target vessel patency, and we know that these patients have, especially in the emergent cases, a higher risk of spinal cord ischemia, I would always go for fenestration if I have the option to do so. So the thinking behind that is, of course, PMAG is as similar as it gets to a custom-made device. It is a custom-made device in that sense. So I would always argue that also in the emergencies, the anatomy of a pyrenal aortic aneurysm is more suitable for a physician-modified endograft than an off-the-shelf device, which bears higher risk of spinal cord ischemia, higher risk of late interventions and occlusions of the target vessels. And in the elective setting, of course, we are in agreement that a custom-made device should be the way to go.
Nikos, you know, PMAGs is very interesting because it started and really took off in the US as a result of lack of access to devices, let's be honest. And it has matured now to a technique that a lot of centers use. And from what I'm hearing here in Europe, even centers that have access to CMD, to off-the-shelf, you do believe there is a potential role for PMAGs?
I think so. I think so in selected scenarios, and it is very variable to the geography, very variable to the preference of the centers, and it's also very variable to the experience of the centers. So we are seeing more and more centers also in Europe who are now gaining experience being interested in physician-modified endografts. The reasons for that are the logistics behind the CMDs. Big centers sometimes have extreme difficulties in the logistics, the waiting times, and so on. The second problem is the issue of costs. not every country in Europe has the ability to invest huge amount of resources, of money in ordering these custom-made devices, which are not always cheap. And a lot of countries need another option, which is as close to the custom-made devices as possible.
And to that end, Marc, you really showed that not all the PMAGs are the same. Quality control, sizing, planning, specifically the modifications you make, all that can affect outcomes. Can you tell us a little bit of how this evolved on your experience? And right now, in the US and at your center, that we have the TAMBI, there is some additional fenestrated devices coming up the pipeline. Where do you see PMAG going from now on?
Yeah, that's a really interesting question. For me, in terms of putting it in perspective with our modifications, this got brought to everyone's attention when Suku Han published the paper from our international consortium and found that with low profile grafts, the type 3C endoleak rate was 15%, whereas with the standard profiles, it was only 6%. And I was part of that analysis, and I just did not remember having problems with 3C endoleaks. And so we reviewed ours, and it was 1%. That was an average follow-up of 20 months in the consortium, and we were only 15, but still we did it by KM methods. And at 2 years, we were still very low, less than 2%. And our patency was still excellent, 98% at 2 years, but our 1C rate was very low, and it was much lower than seen in that study, but it's also lower than what's seen in a lot of custom presentations. And I think the difference is that I trained under Mark Fillinger, and he taught all of his people to put a cuff of PTFE around it. And then for me personally, rather than using a gooseneck snare like I think most people use or used at the time, I just chose a Nestor coil because it will equally show things quite nicely, but also that extra fuzz will, I think, maybe cut down on 3C leaks. So that combination might be what's doing it. I know that other people that have trained under Mark Fillinger also use PTFE cuffs like Adam Beck and Bjorn and several others. And we're going to try to pool all of our data together, because if their results match what we found, then I think it's something that maybe more people should be doing, including industry, even on the custom grafts. So you asked where it fits in now. We do have access to TAMBI. But as Nikos was pointing out, I can cover a lot less thoracic aorta and possibly have better patency if a fenestration would work better. And even if it's a branch graft that I make myself, I can make it with less aortic coverage. So I'm torn a little bit. We should be using custom grafts for the quality control, but at least I'm doing it with an IDE, so the results are very carefully followed and presented to the FDA.
What is the magic number, you think, for industry that's thinking about creating off-the-shelf devices for juxtarenal aneurysms, of how much coverage is really acceptable?
So we know that we can get away with juxtarenal aortic aneurysms with going about 30, 40 millimeters above the celiac trunk. To my knowledge, there's no graft that can get away with less than 60 to 70 millimeters above the celiac, even if it's a short seal branch device. I think these 40 millimeters are probably acceptable. The 60 would also be acceptable in quite a few cases. But the truth is, we are in a point of the aorta where we have some of the crucial segmental vessels coming off, and we really don't know, even if we do not believe in the Adamkiewicz artery principle anymore, we don't know how relevant this segment is always going to be. And it's probably still very relevant, so the less is always better.
So I think with the TAMBI, you're at 6 centimeters. You also have the G branch, which has a cuff of around 4, so you're ending up at 5 centimeter coverage. So I think with these devices, and they have shown, and not a lot of patients, but they have shown 0% spinal cord ischemia in 15 patients. So it's very early data, but I think we're getting there.
there is no question, fenestrations for juxtarenal aneurysms perform very well with respect of occlusion long term. How much that affects your decision making in terms of whether you do TAMBI, PMAG, off-the-shelf devices? Here in Europe, you have a wide range.
Well, if I may start, I mean, that's why for juxtarenal, I always try to go for custom-made devices. So I have my fenestrations there at that level. If it's a juxtarenal where, as I mentioned before, if I only need 2 fenestrations and have all the time in the world, it's a symptomatic but not ruptured case, I would go for a PMAC as well, because nowadays we're going to get more and more standardization how to perform those fenestrations as well. But in a ruptured case, it's about saving lives. And then for me, an off-the-shelf device, SAC, if you have a high experience, you can even do it in local anesthesia.
What's your perspective, Marc, on the renal issue?
Yeah, I prefer the fenestrations, and if I've got a stable rupture, then I would probably still do the PMEG. And I also, I try to, balance that risk of spinal coverage with the ability to fail forward. So I tend to do 4-vessel repairs, and with, about 4 centimeters above that, so that if I do need to put a proximal extension on, it's less complicated in the future. But again, that's a balance with, that is this going to fail 5-10 years in the future, and what's the risk to the spinal cord now?
I think one point that we need to consider when we're talking about branches and parallel aneurysm is the diameter of the aorta at that level. We're not talking about a thoraco-abdominal aortic aneurysm where the branches have space and they are easy to cannulate and without being compromised. But if you would ask me, what would I prefer for my renals? I would always go for a fenestration instead of a branch, especially in a narrow lumen of a juxtarenal aneurysm.
And last, do you think the industry should come up with kits or devices that made it easy to do PMAGs?
I think it does. I think standardization is important, especially if it's going to be done widely. And since, we're not requiring IDEs for people to do this, I think that standardizing things as much as possible is a good thing.
I couldn't agree more. I think industry should go that way and help us and provide all the tools we need to provide the best results. Having said that, we should also be very cautious in the process of not overusing these physician-modified endografts and not making them a potential dreadful complications pattern for our patients, because the process, as we know it from the US experience, is long. The learning curve is long. So if we go that path for also half elective patients or elective patients, then we have to go through a very high standardization process and training process of the ones who are going to start doing these things.